Thank you. I'm Steve Raman from UCLA, and I'd like to speak about integration of histology, genomics, and proteomics with MRI. And I want to thank again Faye for the invitation. These are my disclosures. In this talk, we will focus on how MR correlates with aggressive prostate cancer histology, radiomics correlate with aggressive prostate cancer features, and MR visible tumors in general correlate with aggressive biology downstream, including genomics, radiomics, and now proteomics, with unfavorable outcomes. MR has really revolutionized prostate cancer detection and grading with T2-weighted imaging, diffusion-weighted imaging, and perfusion-weighted imaging as the mainstays of multiparametric MR. In some centers, this is supplemented with MR spectroscopy, and now we have MR PET to improve the detection, and especially for metastatic disease. MR targeted biopsies, now the mainstay for detecting clinically significant disease. And MR enables us to do both focal and whole gland therapies in a more mature fashion. As an example, let's look at the 65-year-old man with elevated PSA and negative trust biopsies twice in the past. Here on this MR, we see a T2 hypointense region in the anterior horn on the right side, which is restricting in diffusion and with an aggressive, very rapid uptake on the perfusion curve for a PIRADS 5 of 5. So this patient underwent, in this case, in-bore biopsy, where we took 5 cores, 3 in the lesion and 2 in the penumbra, and showed Gleason 3+4 cancer. So now this tells us that this visualized lesions has much worse biology than either the regions around it or MR invisible lesions. At UCLA, we've designed, thanks to Dr. Su and Ensman, the integrated diagnostics database, where we in real time acquire all quantitative imaging, MR, PET, and other imaging modalities, correlate that with histology on biopsy and whole radical prostatectomy, and then enable us to get the genomic and proteomic expression data and correlate that with the clinical outcomes. And this really enables us to do artificial intelligence and informatics and other disciplines in this very curated data set. So, for example, we can take a T2-weighted image, it's preoperative, show a lesion here, image that radical prostatectomy specimen in ex vivo MR fashion, show that lesion, same lesion here, and show us that MR visualized lesions on whole mount histopathology, precisely cut with a 3D printed mold, show that these lesions that are visualized are much more biologically aggressive than invisible lesions that we didn't see on the MR. We've known that MR predicts aggressive prostate cancer histology. So in this paper and another subsequent paper in European Urology, we've basically shown that in MR visualized lesions like this lesion on the left is much more biologically aggressive than this invisible lesions on the right. We've shown that MR enables us to detect between 70 and 80% of all clinically significant prostate cancers, up to 90% of solitary clinically significant prostate cancer. We've shown with PSA PET and MR that we are able to detect almost 87% of all clinically significant lesions and detect a smaller proportion of clinically insignificant lesions. So MR and PSMA together probably give us right now the best way to detect all significant prostate cancer. We know from the PROMISE and PRECISION trials that MR visualized lesions and biopsied lesions give us the best window into clinically significant disease. They also said that this was in excess of the systematic biopsies. However, when we looked carefully in over 1,000 patients at the systematic biopsies, we found that the vast majority of clinically significant systematic biopsies were within the penumbra of the MR visualized target. So the MR visualized target here, systematic biopsies within 1 to 2 centimeters in the penumbra of those targets. And actually on the contralateral side, less than 3 to 4% of the time was there any clinically significant disease. So this is an important concept of the regionally targeted biopsy. We've known that diffusion-weighted imaging especially correlates with aggressive histology, with increasing Gleason group scores with decreasing ADC. And that's been known for now a long time. We've recently shown that decreasing ADC on diffusion-weighted images and increasing perfusion parameters correlate and help us find cribriform and intraductal carcinomas as well. Radiomics, which is a discipline of looking at the non-visualized MR features, basically enables us to segment lesions, extract a number of features on the grayscale imaging, assess the heterogeneity of these features, form habitats, and then build predictive models of these habitats, correlating that to biology. In this review article, it's been shown that radiomics improves diagnosis of prostate cancer grading, and then enables us to look at PIRADS 3 lesions and improve their detection and diagnosis and predict BCR. So all of this enables artificial intelligence-based approaches to supplement our visualized diagnosis of prostate cancer. Radiogenomics is an exciting field where MR visualized lesions or visible lesions have aggressive genomic alterations. This was shown in this excellent review paper by Dr. Emberton, showing that MR visualized lesions have more aggressive commercial assay patterns, DNA-related features, transcriptomic features, biological hallmarks of cancer, biological pathways, and cellular structural components in their genomics. We've shown that MR improves the performance of Oncotype DX. Increasing PIRAD scores lead to increasing Oncotype scores. Others have shown that this also applies to decipher tests, where MR visualized lesions have much more aggressive decipher scores than MR invisible lesions, 82% of which were low risk. This has also been shown where decipher improves the prediction of lymph nodes in the radical prostatectomy setting, where aggressive MR and aggressive decipher scores predict more metastatic lymph nodes as you'd predict. MR and 4K tests are also additive. In this paper, basically, high PIRAD scores resulted in very high 4K test scores. The two together resulted in the best performance, although not by much. MR itself was pretty good. This has been shown with the PCA test, where higher PIRAD scores resulted in more clinically significant disease being detected on PCA. In this paper, from Dr. Kim's group, MR visualized lesions had a much higher subset of mitotic cycle, protein folding, cell cycle, and mitotic cycle process components, as well as cell division DNA repair, compared to MR invisible lesions. In this article from Germany, they've shown that the decipher of MR visualized lesions on biopsy closely correlate with radical prostatectomy genomics. So high MR scores with high decipher scores predict what we see on radical prostatectomy. Transcriptomics have been shown to correlate with radiomics. And in this paper, after carefully segmenting both lesions and the whole prostate, selecting features on T2, ADC, and diffusion-weighted imaging, they've shown that a variety of MR-based non-visualized predictors were correlated with high transcriptomic and more aggressive transcriptomic features, including decipher mean scores. Dr. Boutros' group here has shown that MR visualized lesions are enriched with high mutation density, higher prevalence of IDC and cribriform architecture, and overexpression of a non-coding RNA such as SHLAP1. And this is extended to radioproteomics, where for the first time we've shown visualized lesions of tumor, MR visualized lesions have a different proteomic pattern predicted by the genomics with androgen response, DNA repair, and other targets compared to invisible lesions, directly influence survival, and that these aggressive patterns result in poorer survival. So this is the concept of nimbosis, where MR visualized lesions are more polyclonal, more hypoxic, more unstable, have higher risk of IDC and cribriform patterns, and result in poorer outcomes. So a gathering of clouds and predicting downstream genomics and proteomics. And finally, MR visualized lesions and MR visualized lesions have much worse biochemical recurrence patterns, metastatic disease patterns, prostate cancer specific mortality, and other all-cause mortality compared to MR invisible lesions, as in this paper from Sloan Kettering. So in conclusion, multiparameter MR visualized prostate cancer lesions are more aggressive on histology, radiomics, genomics, transcriptomics, and proteomics. And this is only going to be supplemented with artificial intelligence and other modalities for a much more personalized evaluation of individual patient risk. I thank you for your attention.